All right, so we're back. Senate Health and Welfare, and it's still January 29th, and we're still Senate Health Office. So we're beginning to see bills come into the committee. So I thought it would be helpful to take a little bit of time and look at what we have now. And I know there will be others. And just as a heads up for everyone in the room and for us as a committee, as you know, there are a lot of sort of visible issues out in the media around hospitals, around insurance companies, access to care, transformation of our care system, expenditures administratively at hospitals that people are getting very upset about. And so we all know that healthcare has become very expensive and costly, not just for school teachers and for school boards, but also for any person who's working. And we're seeing projections of these very high cost premiums, and it's not to be blamed on anyone or anything, except we need to solve the problem. So all of us have been thinking about how to solve the problem, and some of these bills relate to that. I'm working on bringing in some folks to help us understand the system of care, hospital funding, and so on. And I'm working with Jen a little bit to bring in some, a proposal.
Only have 16.
Yeah. So I'm going to be bringing in some language at some point to put on the table that then our committee can work on as a committee bill, and that everyone else who is interested, everyone else, I say that, not, we'll try to get as much testimony as we can on our proposal. It will probably, sections of it will have to visit other committees down the hall. That's the way life goes. And we'll be working closely with the House Healthcare Committee on information that will inform that bill. So just to tell you that there's a lot going on that we want to be involved in and to help solve some of the high cost problems that we're seeing and the challenges that are faced by regulators, the Green Mountain Care Board in particular in the state, and the challenges that our insurance companies are facing. And we're not layering on right now, but we're very cognizant of what's happening at the federal level. So it's not a good place. So having said that, as you know, there was the Green Mountain Care Board had a report done by the Oliver Wyman Group, and the report that came back in had some recommendations, and one of those recommendations related to the CON process. And so I'm going to have Senator Douglas explain. So we'll look at that bill, and I think rather than my introduction to the bill is I'm following up on the Oliver Wyman report and the recommendation of the Green Mountain Care Board to change the CON process and to increase the threshold for when a structure or a program is evaluated. So how much it costs, how much does the project cost, and does it have to go through a review at the Green Mountain Care Board? And the recommendation is we should raise that threshold so it does not have to go through the review process. And one of the comments that was made by Dr. Hammery of the Oliver Wyman Group is that this will increase competition, but it will also help have more facilities in place without the bureaucratic process of review. So S10 and S20 are both relate to that. They're very similar except for the threshold amounts. And so I'm not gonna say any more. I might say more later, but I'm gonna turn it over and let Senator Gulick say a few comments. And then we'll bring Jen up to talk about the CON process, what's in the bill, and what are the differences between the two.
Great. Can I speak from here? Would you like me in the hot seat?
No, stay right there.
Okay, great. We're all here to solve problems. We have a healthcare cost crisis, and you could argue that possibly also an access to care. And I think for me, having looked at the Oliver Wyman report as well, we wanted them to tell us what we need to do to make the system better. So I believe that we should be seriously looking at what they proposed and trying our best to implement some of their suggestions. And this is one of them. I didn't know what a certificate of need was when I first got here, but I do now. And it's been a fascinating journey. So for me, and by the way, I'm on the front lines of building a new high school in Burlington, and I can tell you building costs have really increased. You can't do much without spending a lot of money. So that's why I was, really enthusiastic about raising the thresholds to an even higher level that is proposed in S10. So I hope that perhaps we can think about finding a level that will really allow us to increase access and expand healthcare services to all folks around the state, while also recognizing the importance of our hospitals. We love our hospitals, but this is something that we need to do. So thank you for listening, and I will cede my time to Ledge Council, who I think will go into the bills.
Right, so I think, this is good. The process has been, the Oliver Wyman report came out in the summer. There was a lot of attention given to it, and then many of us, the report is part of a larger healthcare transformation that's going on and community engagement process. So this is one chunk of it, one small tiny piece of all the work that's going on out in across the state in terms of looking at how we can improve access for community services, hospitals, for folks getting the services they need. And so what I'm going to do is, so every bill that we're looking at, I think, kind of relates to the work that's going on. That's a result of Act 167. We'll keep talking about Act 167, and we'll come back to it.
Okay, at some point, it might be helpful, because I don't remember what's in Act 167. I'm sure that
It's on our agenda.
there. So, yeah, or just a summary as to what it did, and at some point, what the vision is, where we're going.
I can do that. And actually, last night I pulled up a summary sheet for.
It's probably right.
Yeah, we have it, and I'll get Kiki to post it, and we'll also be putting Act 167 up on our agenda, and we'll have the Green Mountain Care Board and we'll have AHS in to talk about where we are with it, and then we'll also be looking at what's happening next. So next step.
That would be.
We have Green Mountain Fair Board in for, I'd like to hear them talk about their approval process and what kind of reviewing process.
Right, so here's that, so just, this isn't, thank you for that. This is your first time looking at a bill.
Thanks, man.
Probably should have said that right off the bat. So what we do in here, first we familiarize ourselves with what's in the bill. We'll go through it with the sponsors of the bill. Senator Gulick is a sponsor of one, and I'm a sponsor of the other. So there's a minor disagreement about how that should happen. So can we solve the money problem? That'll be one of the questions. After we've familiarized ourselves with the bill and we've had Jen walk through it and answer questions about what's in there, including what is a CON, then we'll invite testimony. We'll sort out which of these bills we want to take full testimony on, once we do that, that means we're starting to get serious about passing the bill out of committee. So after we've done that, we'll do exactly what you've asked for, Senator. Thank you for that. Appreciate it. Okay. Are we good? Any other questions? Perfect. Thank you, Jen, and for being here.
Good morning, Jen Harvey from the Office of Legislative Counsel. So we are going to look at the bills, but I thought based on some of what the chair said, I think what would be helpful first is to put up the statute at the beginning of the subchapter on certificate of need, just that kind of sets the stage for what the subchapter is about, what these laws are about, and why Vermont adopted them in the first place. So this is just to orient you. We are in Title 18, which is the biggest chapter, or the biggest title on health laws. We're in a chapter on healthcare administration. We're in a subchapter on health facility planning, and so that's really what we're talking about. We're talking about certificate of need here is about health facility planning. And that policy and purpose that was enacted when this chapter was first added in 1979. Is that it is declared to be the public policy of this state that the general welfare and protection of the lives, health, and property of the people of this state require that all new healthcare projects be offered or developed in a manner that avoids unnecessary duplication and contains or reduces increases in the costs of delivering services, while at the same time maintaining and improving the quality of and access to healthcare services, and promoting rational allocation of healthcare resources in the state, and that the need, cost, type, level, quality, and feasibility of providing any new healthcare project be subject to review and assessment prior to any offering or development. So this is the idea that before any new healthcare project, which is a fairly broad definition that includes, in many cases, a new type of service, is offered in this state, that there be a review and assessment first to avoid unnecessary duplication, contain or reduce increases in the cost of delivering care, and also ensuring that we have high quality and good access to services, and that healthcare resources are appropriately allocated across the state. That's kind of why certificate of need, at least why these provisions were initially enacted, and that has been amended over time. So there are provisions in the chapter that set out the process for a number of definitions, that it establishes what types of projects require a certificate of need, and certificate of need is really a finding by the Green Mountain Care Board. It was previously, prior to the Green Mountain Care Board, it was the Department of Banking, Insurance, Securities, and Healthcare Administration, GISHCA, that there is a need, that is a need for the type of facility or service that is being offered. And there are certain jurisdictional triggers that trigger the Green Mountain Care Board's authority to say yes or no to a new project. And so that's really what we are looking at in these bills. So let's start with, get your body close. Start with H10, which, as the chair and Senator Gillick noted, that there are a lot of similarities between the bills. I know, I'm trying to get the right thing up. I have too many tabs open. All right, S10. So there are some differences between them. And because this is the first time we're going over a bill in this committee this year, we have new members. I want to make sure I'm taking it slowly. So first of all, the reason I'm the one walking you through the bill is because I'm the one who drafted the bill. And that's typically what you will have, is you will have the legislative council attorney who drafted the bill in here to do the walkthrough. So we'll start with S10. It was introduced by Senator Hardy and the chair. And all bills start out as introduced with a subject line that just describes some of the main topics that somebody might use to search for the bill on the website. And then a statement of purpose of the bill as introduced, which is a plain language description of what the bill does. And so for some bills, especially as a number of bills start coming out pretty quickly in various subject areas, this may be the only part that some members read on certain bills, or at least read this to see if they want to look further into what the bill is about. So this bill proposes to modify the requirements for obtaining a certificate of need before offering or developing a new healthcare project, including increasing monetary thresholds and eliminating the requirement for certain projects to obtain a certificate of need. And we have the title of the bill on line 11. And what's important here, especially because there are two bills dealing with certificates of need, is that I tried to give them slightly different names while also still telling you what the bill is about. So this one is an act relating to modifying requirements for obtaining a certificate of need. And this section 1, we're amending an existing statute, 18 VSA, section 9434 is an existing statute that sets forth the general rules for obtaining a certificate of need. And it says that a healthcare facility, and this is existing language because it's not underlined. So the existing law says that a healthcare facility other than a hospital, and you'll see other provisions for hospitals, shall not develop or have developed on its behalf a new healthcare project without issuance of a certificate of need by the board. So that's the existing certificate of need. We often call it CON requirement. The existing CON requirement is that a healthcare facility other than a hospital cannot develop or have developed on its behalf a new healthcare project unless the Green Mountain Care Board has issued a certificate of need. And it describes what a new healthcare project includes. So it can be things relating to the physical structure, construction, development, purchase, renovation, or other establishment of a healthcare facility, or a capital expenditure by or on behalf of a healthcare facility for which the capital cost exceeds. And under existing law, the statutory number here is $1.5 million. There's language you'll see coming up a little later that gives the Green Mountain Care Board the ability to adjust these thresholds in keeping with the consumer price index increase in the inflation rate. But the statutory rate, at least, that is the basis from which they are adjusting, is 1.5 million for a non-hospital. And this bill would increase that threshold to 5 million.
Can you characterize a non-hospital healthcare facility? So we're not talking about somebody opening up a doctor's office on the corner.
Yes, great point. Let me go back to statute here and our definitions, because I think that definitions, and then there's also some exceptions, but starting with the definitions. So there's definitions here in this same subchapter, health facility planning. Right after the policy and purpose section, there are definitions, a bunch of definitions. But for our immediate purposes, we're talking about healthcare facility, and it means all persons or institutions, including mobile facilities, whether public or private, proprietary or not-for-profit, that offer diagnosis, treatment, inpatient or ambulatory care to two or more unrelated people and the buildings where those services are offered. It specifically includes all types of hospitals, nursing homes, health maintenance organizations, home health agencies, outpatient diagnostic or therapy programs, kidney disease treatment centers, mental health agencies or centers, diagnostic imaging facilities, a number of other things, and also inpatient or ambulatory surgical diagnostic or treatment centers. And then later in this same chapter, there is a section on exceptions. So for right now, we're talking about not hospitals in the bill. We're talking about this other group of this types of facilities or service providers. And then we have exclusions. So who is accepted? And some of these we may see coming up in the bill as well, but we will look at them on here. So exclusions, excluded from this chapter, so not needing to get certificate of need, are offices of physicians, dentists, or other practitioners of the healing arts, meaning the physical places that are occupied by those providers on a regular basis where they do their work. So as the chair is saying, this is not just a doctor's office. It's not subject to a certificate of need requirement that is carved out. However, if it is part of a hospital, if the physician's office is part of a hospital system, then it may still be depending on the size of the facility. Also excluded are community mental health or developmental disability center healthcare projects proposed by a designated agency.
Question.
Is there any explanation as to what the rationale was behind these particular exceptions or?
Sure.
is that-
That's another
Yeah, that's just
question.
another day. Okay.
Well, I think at the time, I'm sure there was, most of these exclusions predate me. But I think there was perhaps not significant concern about the number of independent physician offices around the state. And there is a significant cost involved in going through a certificate of need process.
Right, a single physician could, if you had a small office and it had to go through a CON, you might not.
Okay,
Yeah,
okay.
When I started, the concern was things like imaging, MRIs.
Right.
Because once you had one, once you did enough procedures to pay for it, it was gravy. And the concern was you would use it more than you actually needed to use it. And that was a
Overutilization.
higher billing.
Yeah.
Right, sure.
Gotcha. Thank you.
And Bishop was very on top of that.
they were on it. They were.
All right, so this is our first change here proposed in the bill is for a non-hospital healthcare facility, the construction or other establishment of a facility or capital expenditure for which the capital cost exceeds, and the change is from 1.5 million, which has already been indexed by the Green Mountain Care Board, higher than that, to 5 million. There are some other provisions in existing law that are not changing. Do you want me to just focus on what is changing?
Yeah, or you can do that. I mean, you could generalize what's there contextually.
All right, the next, so we're not changing anything about the change from one licensing period to the next and the number of licensed beds in a facility through addition or conversion or a move, or the offering of a home health service or transfer of majority ownership interest in a healthcare facility other than a hospital or nursing home. But then we get to the purchase, lease, or comparable arrangement of a single piece of diagnostic and therapeutic equipment. So these are kind of big purchases that a facility might be making, for which the cost exceeds, and under existing law, that's in excess of $1 million, again, as indexed upward slightly by the Green Mountain Care Board, and they can give you their current threshold. But this would move that up to 3 million. And then there's some questions.
I'm scrolling through my own bill here and trying to remember. Okay, we do have replacements in the bill.
All right, then we have the offering of a healthcare service or technology with an annual operating expense that exceeds, under existing law, the statutory number there is 500,000. This bill would increase that to 1.5 million, either of the next 2 budgeted years. If it wasn't offered by the facility within the previous 3 fiscal years. No changes on the ambulatory surgical center in this bill. Then we have hospitals. Those non-hospital thresholds are higher for hospitals. So under existing law, again, a hospital cannot develop or have developed on its behalf a new healthcare project without a certificate of need from the board. And for purposes of this subsection, new healthcare project is construction or other establishment of a healthcare facility or capital expenditure for which the capital cost exceeds. And under existing law, we are at 3 million. This would increase it to 10 million, increasing that threshold. Hospital, I'm just going to shorthand it as hospital construction project to $10 million.
Will be interesting to know what a $10 million project looks like and what it is.
Yes,
Yeah.
and I think when we go through the other bill, I will remind you what the
Yeah.
numbers were in this bill, so that you can
Good.
speak in terms of those. The purchase, lease, or other comparable arrangement of a single piece of diagnostic and therapeutic equipment, for which the cost is in excess of, and this would increase that number from 1.5 million to 5 million.
And it does include donations, which is underlying
Yep.
statute.
Yes, exactly. trying to hit the icons here. The offering of a healthcare service or technology with an annual operating expense that exceeds, and this would increase that number from 1 million to 3 million for either of the next two budgeted fiscal years, if that was not previously offered within the previous 3 fiscal years. And then similar language from the non-hospitals around change in the number of beds and offering of any home health service. Then we have for very large projects. So in the case of a project that requires a certificate of need and the expenditures are anticipated to be in excess of, and under current law, that's 30 million. This would increase that to 100 million. The applicant first has to secure a conceptual development phase certificate of need. So it's kind of a preliminary before anything is really moving forward, an earlier certificate of need that allows the applicant to spend for architectural services, engineering design services, or any other planning services. And then there would need to be another certificate of need after that for the actual project. And then there's just a conforming number change here where the applicants are not subject to sanctions for failure to comply if they made a good faith reliance on verified project cost estimates that would have led a reasonable person to think that this project was not going to trigger that conceptual certificate of need threshold. But it actually did. So that again is matching that change from $30 million to $100 million. And then it does allow a certain amount of expenditures made in preparation for getting the conceptual development phase certificate of need. And this increases that threshold from 1.5 million to 5 million for non-hospitals and from twice that 3 million to 10 million for hospitals. And then there's some existing language saying if the board finds out that somebody who had to get a certificate of need actually split their project up into smaller components that don't really make that are really part of a larger project in order to try to avoid the certificate of need requirement, then the person still has to submit a certificate of need application. And then there's the existing language that says the board may periodically, this would change that to shall, adjust the monetary jurisdictional thresholds in this section. That's that indexing I was saying. This would strike language saying that the board shall reflect the same categories of healthcare facilities, services, and programs recognized in this section. And that strikes language saying that any adjustment by the board shall not exceed an amount calculated. And instead just says, so right now it says any adjustment by the board cannot exceed an amount calculated using the cumulative consumer price index rate of inflation. This just basically simplifies all of that to say the board has to adjust these monetary thresholds annually using the consumer price index rate of inflation. So that isn't necessarily a substantive change. Then we get to those exclusions. So this would add some changes to the exclusion. So this is section 2. We're now amending 18 VSA section 94.435. And this would amend an existing provision on exclusions from the certificate of need requirements. So currently excluded, among other things, are routine replacements of non-medical equipment and fixtures. So this would add an exclusion for medical equipment that is fully depreciated, as well as non-medical equipment and fixtures, regardless of their remaining useful life. So a smaller category of medical equipment than non-medical equipment, just medical equipment that is fully depreciated. So if they're replacing something that is basically at the end of its useful life, they don't have to get a certificate of need for that routine replacement. And then that's a confirmed change. And then also, no, right. So this is a little different from what you'll see in S20. So you may want to, exactly. You may want to pick and choose if you take these up and you can harmonize the two bills. Also excluded from this subchapter under this bill are emergency and non-emergency ground ambulance services, affiliated agencies, and equipment and supplies used by emergency medical personnel. And we're just piggybacking on definitions that exist in Title 24 around emergency medical services. So that's what it says as those terms are defined in another part of the statute.
Yeah, the replacement, this bill, was done in collaboration with the Green Mountain Care Board, but I also know that there are interests in Senator Gulick's bill, other folks who I didn't have time to respond to, and we've done that, so that'll be good. We'll get everybody in the room to help us.
And then always the last section of a bill is the effective date, and this act would take effect on July 1st, 2025. We take down this one and put up S20.
Questions on this one? Or the, the whole process stuff? Okay. So the question, Jens, within the underlying statute, there's direction to the board to write rules regarding the CON process. There are other guidelines included.
I don't know. There's no specific standalone rulemaking section, but there may be authority elsewhere or on.
I was just thinking probably in the,
I do believe
Green Mountain Care Board.
Yes, I do believe they have.
Yes,
Because that's where,
yeah.
and I believe they issue annually a bulletin with the updated amounts,
Right,
which I think is on their website.
right. And we're gonna have questions about what can you build for $10 million or not.
Well, I encourage you to ask those of other people. 'Cause I-
Well, yeah, we will. They're sitting in the room, so.
Sorry. All right, so then we will look at S20. And S20 is introduced by Senator Gulick and others. And again, we've got these subjects. And again, we have the statement of purpose of the bill as introduced. And this one, again, proposed to increase the monetary thresholds that trigger a certificate of need requirement. And then in this one, I've said, and to exempt healthcare services and healthcare facility projects that are the result of a contract awarded by the state of Vermont. So that's the new exclusion in here. And this one is entitled An Act Relating to Increasing the Monetary Thresholds for Certificates of Need. And again, we are amending this same section in section 1 that was amended in section 1 of S10, 18 VSA 9434. We're starting out with the non-hospital facilities. And in this case, and I'm going to follow along here so I can tell you the differences. This would say that a certificate of need is required for, I'm just going to shorthand to construction, before construction of a non-hospital for which the capital cost exceeds. This would increase from 1.5 million to 10 million. S10 would give you 5 million. S20 would give you 10 million. Sort of handy. The numbers are
There might have been a sweet spot in there.
bill numbers are multiples of each other,
Right.
multiples of each other, and so are the increase. So we're gonna go 7.5. Compromise at 7.5. Can do that, man.
So could I say something right here? Because we have two bills very much alike, two different positions, and one, obviously worked with the board, and then there were other folks who were working on this one and giving input. And so,
But I did ultimately also interact with the board.
no, that's fine.
Yeah,
Okay. Yeah. So, but there are different things here. So our work going forward will be to figure out what's the right spot. And I am not, wedded in any or passionate about a specific number. I'm hoping that Senator Gulick isn't either, but she is. She's more passionate.
There's no fighting.
Yeah, we're gonna have
State
a knockdown
board.
and drag out, but
Yeah.
we'll have folks in who will help us understand. Maybe one of these is better than the other. And I'm very much open to figuring out what's the best course of action.
All right. Next, we go down to number 4 on the list, which is the purchase, lease, or comparable arrangement of a single piece of diagnostic and therapeutic equipment that costs, and under current law, that's more than $1 million. This bill would change that to more than $10 million. The previous bill we looked at would be $3 million. So you have proposals for increasing that 1 million to either 3 million, or in this bill, 10 million.
So I can think of a case where the diagnostic and therapeutic equipment might achieve $10 million, particularly with the new it's digital data sensing system for surgery and stuff. So, yeah, so that's a good discussion.
Then we have number 5, the offering of a healthcare service or technology with an annual operating expense that exceeds, and this bill would increase that number from 500,000 to 10 million. The S10 would increase it from 500,000 to 1.5 million. So this is a difference of 1.5 million to 10 million. And then number 6 is new just to this bill. So an S20 only, under existing law, there is no monetary trigger on the construction, development, purchase, lease, or other establishment of an ambulatory surgical center. It just requires a certificate of need regardless of the amount. This would add to that or the expansion of an ambulatory surgical center. And then it would say for any of those for which the cost exceeds $10 million. So this would allow a smaller, possible to build, develop, purchase, lease, or otherwise establish or expand an ambulatory surgical center for less than $10 million, then under this bill, that would not require a certificate of need. Then we get to subsection B, which is about the hospitals. And we get first to what I'm calling for ease of reference, the construction. So construction project, this would actually, both bills are the same in proposing an increase from $3 million to $10 million. Parity there. Number 2, the purchase, lease, or comparable arrangement of a single piece of diagnostic and therapeutic equipment for which the cost is in excess of, under existing law, that's 1.5 million. This bill proposes $10 million. S10 would propose $5 million. We get in number 3, the offering of a healthcare service or technology, and we're in the hospital world now, having an annual operating expense that exceeds, this bill would increase that from $1 million to $10 million for either of the next 2 budgeted fiscal years. S10 would increase that from $1 million to $3 million. And then the threshold for a conceptual development phase certificate of need under existing law is 30 million. This is a case actually where S20 has a lower increase. So this would increase to 50 million. S10 would increase that to 100 million. So this is the jurisdictional trigger for getting the conceptual development phase certificate of need as well as a standard certificate of need. And again, that same conforming reference on the next page, just about somebody not being in trouble if it was reasonable to think that the project would not reach that threshold, and it did. And then this bill would allow expenditures in preparation for obtaining a conceptual development phase certificate of need. It would increase that under existing law to $1.5 million for non-hospitals and $3 million for hospitals. This would increase for all facility types to $10 million. Whereas S10 would increase from 1.5 million to 5 million for non-hospitals and from 3 million for the same 10 million for hospitals. And if it's helpful, if we're looking at both those in the future, I can certainly put a side by side of what these numbers are.
That would be good.
For our initial walkthrough. This does not, S20 does not make any changes to the language in subsection E at the top of page 6 about the board's periodic adjustment of the monetary jurisdictional thresholds. As I said, there isn't really a substantive difference. The S10 version streamlines that language a little bit and takes it from a may to a shall. But it's my understanding the board does this annually already. So in practice, it's not especially different. And then we do have a difference in the exclusions, so that fully depreciated medical equipment that was excluded in S10 is not excluded in S20. Instead, S20 excludes the offering of a healthcare service or the construction, development, purchase, renovation, or other establishment of a healthcare facility that comes as the result of a contract awarded by the state of Vermont. And this act would similarly take effect on July 1st of 2020.
Question for Jen. So the question we haven't asked, I think, but we will ask questions. And one of the questions I think we might want to be interested in is what, if any, effect will this have on increasing or decreasing overall costs? Healthcare costs. So if you open it up for expansion to a higher level, will it make the build out more efficient and therefore lower cost? Or will it allow for increased development that was maybe unexpected and increased costs? So I don't know the answer to that.
Yeah.
Which way or this way?
My hospital doesn't have an MRI, so if you need an MRI, you go to Burlington or Chicago. But if they had an MRI, it would be much more convenient for their patients to not have to go there. But if there's room to go there, you know, you don't have to wait 6 months to get your MRI. Once they have one here, this is the old argument, then the inclination would be rather than do another lesser expensive imaging, you are inclined to do the more expensive imaging. And, you know, I don't, you're throwing around numbers that, you know, I can deal with what a can of tomatoes costs, but you get into 10 million bucks and I don't know what that buys. I mean, what are we talking about, an X-ray machine or an MRI, or are we talking about robotic surgery? What is it that we're opening it up?
So we'll have testimony and that'll help us understand some of the implications and outcomes from what we're doing. Or intensive. But I know that the Oliver Wyman report saw the CON change as important. The board sees it as important, and I think the hospitals and others see it as important, but we need to understand if it will have what is the positive effect for access and what may be the negative effect for cost or overutilization. We don't know.
Can I also just suggest that we look at the plethora of data that exists nationwide around this? Because I started going down.
Oh, yeah.
Well, I mean, there's a lot.
There's a lot, and I think the board will help us with that. That was part of the Oliver Wyman assessment. We won't get into all of it, but we'll have to listen to the folks who have been involved in it. No other questions? Well, it's good timing, because we have another person coming in 5 minutes. And Senator coming to the scoop. So all of you who are sitting in the room, just before we shift gears, we're gonna close up down this discussion. We will be taking more bills up, but I know the Hospital Association is here, the insurers are here. The healthcare advocate is here, and it will be important to hear all these voices. I know the independent physicians are very interested in this to hear. So, and they're different perspectives. There we go. Thank you. Thanks, Jen. Good. We're gonna take a break for 5 minutes and we'll come back. We have someone representing health, mental health advocacy day.